Critical care, trauma, and surgical management essentials. Let's jump right into question 12.
A 28-year-old guy comes in with a stab wound to his left lower chest, right at the 6th intercostal space, anterior axillary line. Fortunately, he's hemodynamically stable. His chest x-ray shows a small left hemothorax, but no pneumothorax. So what is the absolute most sensitive diagnostic modality to rule out an occult diaphragmatic injury here? Are we looking at A, diagnostic peritoneal lavage, or DPL, B, a CT scan of the chest and abdomen with oral contrast, C, serial chest x-rays over 24 hours, or D, diagnostic laparoscopy?
And the correct answer is D. Penetrating injuries to the lower chest or that thoraco-abdominal region, basically anywhere between the nipples and the costal margins, carry an incredibly high risk of an occult diaphragmatic injury. Now, you might think a CT scan is the way to go, but helical CT scans actually have notoriously low sensitivity for those tiny diaphragmatic lacerations. And if we miss a left-sided injury, it can literally lead to delayed diaphragmatic herniation and strangulation years down the line. Direct visualization using diagnostic laparoscopy is the gold standard and the most sensitive modality for a stable patient.
Question 13. A trauma patient rolls in with a severe pelvic fracture and persistent hypotension. This is despite pelvic binding and getting 2 units of packed red blood cells. The FAST exam is negative for any intraperitoneal fluid. What is our most appropriate next step in management? A, immediate exploratory laparotomy. B, a CT scan of the abdomen and pelvis. C, retroperitoneal pelvic packing or pelvic angiography with embolization, or D, diagnostic peritoneal lavage? The answer here is C, retroperitoneal pelvic packing or pelvic angiography with embolization. Think about it. In a patient with an unstable pelvic fracture who just won't stabilize hemodynamically, a negative FAST exam tells us the hemorrhage is hiding out in the pelvic retroperitoneum. So the right move is mechanical stabilization, which we already tackled with the binder, followed by either retroperitoneal packing in the OR or angiography to shut down that arterial bleeding. And a massive exam pearl here, moving an unstable patient to the CT scanner is absolutely strictly contraindicated. Question 14. Which of the following internal organ injuries is characterized by the classic presentation of a delayed hemorrhage that pops up days or even weeks after the initial blunt abdominal trauma? Is it A, liver laceration, B, splenic injury, C, pancreatic transection, or D, small bowel perforation? The answer is B, splenic injury. Delayed splenic rupture or hemorrhage is this really well-recognized phenomenon that happens in a small chunk of patients managed non-operatively. Basically, a subcapsular hematoma or a pseudoaneurysm can just silently wait around, only to rupture days to weeks after the initial injury. When it does, the patient suddenly drops into hemorrhagic shock and complains of intense left upper quadrant pain. Oh, and definitely remember this, that referred left shoulder pain they often feel, that is classically known as Kier's sign.
Question 15. A 34-year-old male is brought in after a high-speed collision, suffering a massive crush injury to his right lower extremity. His urine is dark reddish-brown, and a dipstick comes back positive for blood. But here's the kicker. Microscopic analysis only reveals 0 to 2 RBCs per high-power field. So what is the most appropriate immediate medical treatment? A, intravenous loop diuretics. B, aggressive intravenous fluid resuscitation. C, emergent hemodialysis. Or D, administration of packed red blood cells.
And we're going with B. This presentation is the textbook definition of rhabdomyolysis following a crush injury. Huge amounts of myoglobin are released from those damaged muscle cells and get filtered right into the urine. That totally explains the false positive dipstick for blood because the dipstick is just detecting the hemoiety found in both hemoglobin and myoglobin, even though there are barely any intact red blood cells there. The absolute cornerstone of treatment here is aggressive crystalloid fluid resuscitation. We're targeting a really high urine output of 2 to 3 milliliters per kilogram per hour, specifically to prevent acute kidney injury.
Question 16. During an exploratory laparotomy for a gunshot wound, you uncover an extensive grade 4 injury to the head of the pancreas. We're talking complete disruption of the main pancreatic duct with duodenal involvement. The patient is hypothermic at 34.8 degrees Celsius, acidotic with a pH of 7.12, and profoundly coagulopathic. What is your most appropriate intraoperative choice? A, immediate pancreaticoduodectomy or Whipple. B, total pancreectomy. C, damage control surgery. Or D, primary repair of the pancreatic duct over a stent.
The correct choice is C, damage control surgery. Listen, complex pancreaticoduodenal injuries are highly morbid on a good day, but attempting a prolonged reconstruction like a Whipple when your patient has already entered the lethal triad, which is hypothermia, acidosis, and coagulopathy, will absolutely result in intraoperative death. The action here is non-negotiable. You control the hemorrhage, terminate the laparotomy with wide drainage, throw on a temporary closure, and rush that patient straight to the ICU. Any definitive reconstruction has to wait at least 24 to 48 hours for metabolic correction. Question 17. Which of the following injuries is considered an absolute indication for immediate operative intervention, rather than trying out a trial of non-operative or angiographic management? A. A grade 5 liver injury with a transient response to fluids. B. A penetrating abdominal wound with evisceration of bowel loops. C. A grade 4 renal laceration with perirenal hematoma on CT. Or D. A high-grade pelvic fracture with contrast extravasation on CT.
Answer B, penetrating abdominal trauma that involves evisceration of abdominal organs or bowel loops is a hard, absolute indication for an immediate exploratory laparotomy. Evisceration carries a tremendously high probability of hollow viscous perforation and ongoing visceral contamination. If you look at the other options in comparison, hemodynamically stable solid organ injuries like the liver or the kidney, and even high-grade pelvic bleeding are actually frequently and quite safely managed via non-operative pathways or angioembolization.
Question 18. A 22-year-old male presents with a gunshot wound to his left thigh. He's hemodynamically stable and has a non-expanding hematoma right over the bullet trajectory. His distal pulses are easily palpable and symmetric, and his ankle brachial index, or ABI, is 0.95. What's the most appropriate management? A. Immediate surgical exploration. B. A CT angiogram of the lower extremity. C. Discharge home with outpatient follow-up. Or D. Formal catheter-directed digital subtraction angiography.
The answer here is B, CT angiogram. So this patient is showing what we call soft signs of vascular injury, a non-expanding hematoma and proximity to a major vessel. But he completely lacks any hard signs like active arterial bleeding, an expanding hematoma, a palpable thrill, or absent pulses. Hard signs would buy him an immediate trip to the OR. However, an ABI between 0.9 and 0.99, coupled with the structural proximity, definitely warrants further evaluation for occult intimal flaps. A CT angiogram is our preferred, highly sensitive, non-invasive diagnostic modality for a stable patient like this.
Question 19. Which of the following statements regarding blunt thoracic aortic injury is correct? Is it A. The most common site of injury is the ascending aorta. B. Widening of the mediastinum on a screening chest X-ray is a highly specific finding. C. Immediate open thoracotomy with graft replacement is preferred. Or D. The injury typically occurs at the aortic isthmus. The correct statement is D. Believe it or not, more than 90% of blunt thoracic aortic injuries happen right at the aortic isthmus. It's an anatomical transition zone where the mobile aortic arch meets the relatively fixed descending thoracic aorta. That makes it uniquely vulnerable to massive shear forces during a rapid deceleration event. A couple of examples to remember. Mediastinal widening on an X-ray is sensitive, but it's actually poorly specific. And as for treatment, thoracic endovascular aortic repair, or TEVAR, has largely replaced those traditional open surgical graft repairs because it simply has lower mortality rates. Question 20. A 45-year-old guy falls 20 feet from a ladder. He arrives stable. A CT scan reveals free intraperitoneal air, but there is zero evidence of any solid organ injury. What is our very next step in his care? A. Admit him for serial abdominal exams and IV antibiotics. B. Repeat the abdominal CT scan in 12 hours. C. Immediate exploratory laparotomy. Or D. Perform a diagnostic peritoneal lavage. Answer C. Immediate exploratory laparotomy. Seeing free intraperitoneal air, or pneumoperitoneum, on a CT scan after blunt trauma means one thing: perforation of a hollow viscus, until proven otherwise. This is a definitive, absolute indication for an immediate exploratory laparotomy. You have to get in there to identify the perforation, stop the ongoing contamination, and get it repaired or resected right away. Question 21. Let's say during that exploratory laparotomy, you find a through-and-through injury to the mid-jejunum. Fortunately, there's minimal contamination and it involves less than 10% of the bowel circumference. The surrounding bowel tissue looks completely healthy and viable. What is the absolute most appropriate technique for this repair? A. Formal segmental resection and end-to-end anastomosis. B. Primary closure of the enterotomies in a transverse fashion. C. Creation of a temporary loop jejunostomy. Or D. Primary closure in a longitudinal fashion. The correct answer is B, primary closure of the enterotomies in a transverse fashion. When you're dealing with small bowel lacerations that involve less than 50% of the circumference and have a healthy blood supply, you can safely manage them with primary closure. But the crucial takeaway here is the mechanical orientation. The repair absolutely must be performed in a transverse fashion, meaning perpendicular to the long axis of the bowel. Why? Because this guarantees the closure won't narrow the bowel lumen and set the patient up for a terrible postoperative obstruction. A longitudinal closure runs exactly that risk. Question 22. A 19-year-old female is brought in after a motor vehicle crash showing severe abdominal bruising right where her seatbelt was. Her initial FAST exam is negative and her vitals are totally stable. But over the next 12 hours, she develops worsening mid-epigastric pain, vomiting, and a newly elevated serum amylase. What injury should you be highly suspicious of here? A. Diaphragmatic rupture. B. Pancreatic transection across the vertebral column. C. Gallbladder avulsion. Or D. Splenic capsule tear.
The correct answer is B, pancreatic transection. Blunt injuries to the pancreas are very frequently caused by compression forces slamming the organ against the rigid lumbar spine, exactly what happens with a tight seatbelt in a crash. And these injuries are notoriously tricky to diagnose early on. The initial FAST exam and even early CT scans can look completely normal. It's the delayed timeline that gives it away. The development of epigastric pain, persistent vomiting, and that rising amylase 12 hours later reliably points you straight toward a pancreatic contusion or transection. Question 23. Which component of the primary survey in a trauma resuscitation is specifically targeted by placing a cervical collar and stabilizing the head? A. Airway with cervical spine protection. B. Breathing and ventilation. C. Disability and neurological status. Or D. Exposure and environmental control. Answer. The very first foundational step of the Advanced Trauma Life Support Primary Survey is securing the airway with cervical spine protection. Any manipulation of the airway has to be performed while maintaining inline immobilization of the cervical spine. And the reason why is absolutely critical. It is to prevent translating an unstable cervical spine fracture into a permanent, devastating spinal cord injury.